lymphocytes and bone cells, and it can cause the avascular necrosis of the femoral head. Then alcohol, chronic alcoholism can cause the avascular necrosis of the femoral head. Hemoglobinopathy is like sickle cell anemia. In our belt of area, patient from Adivasi belt like Bodeli, Chota Udaipur, it is sickle cell is very common, and we found many patients of avascular necrosis even in young age with avascular necrosis of femoral head. Smoking is also associated risk factor. Then, like myeloproliferative disorders, infection like TB hip, in past it is very common cause of the avascular necrosis of the femoral head. Besides these causes, there are other associated risk factors like chemotherapy, radiotherapy, which causes the direct cellular toxicity of the femoral head cells. Then Gaucher's disease and other atypical risk factors are also present. But in our practice, we routinely see these are common risk factors associated with the avascular necrosis of the femoral head. So this is the one paper which shows the common causes and associated risk factors. So in most of the cases, idiopathic is the most common cause. Then dyslipidemia, hyperlipidemia, which can cause by the steroid use or any other cause, causes the fatty infiltration of the cells, which causes the intraosseous and extravascular pressure increase in the femoral head compartment. It can also cause the avascular necrosis of the femoral head. These are the common percentage associated risk factors of avascular necrosis of the femoral head. So what are the symptoms? So basically, in early stage of the avascular necrosis of the femoral head, there are no symptoms. So in early stage, patient may have occasional pain in the hip joint, or mostly the patient does not have difficulty in the routine activities. So patient will do all his routine activity. He or she can have a mild pain in regular activity and difficulty in cross-leg sitting. Initial symptoms when avascular necrosis progresses, then patient can be presented with the groin region pain, occasionally buttock pain. Very commonly, sometimes misinterpretation can happen when patient have a referred pain. It is very common to have patient can complain the pain in the knee and surrounding area, hip to knee referred pain. When we ask the history in detail, patient can tell the pain started from the hip joint and then referred to the knee joint. But patient commonly presented as a pain in knee joint surroundings. So knee pain can be initial symptoms in many patients. In advanced stages, the mechanical hip pain, like pain during walking or any routine activity on weight bearing, then patient can be presented with the limping. Limping is also one of the initial symptoms. Patient can not have pain, but patient can be presented with limping without pain. And restriction of the hip movement. Specifically, internal rotation of the hip joint is very commonly associated with avascular necrosis of the femoral joint. So during examination, if specifically patient presenting with the hip pain, and if we want to think that if it is a avascular necrosis of femoral head, not in hip examination, in supine position, if patient having a restriction of internal rotation, then we can suspect it can be avascular necrosis of the femoral head, because internal rotation is the first movement to get restricted after avascular necrosis of the femoral head. So, how can we make diagnosis? X-ray is the first choice of investigation whenever patient presented with the pain in the hip region or groin region, but it looks normal in even in early stages. So, it is difficult to diagnose even for orthopedic surgeon with X-rays in the early stage. So, it is a more or less clinical diagnosis in the initial stage. We have to have high suspicion based on the clinical presentation. So MRI is the gold standard. Always do MRI in patients with clinical symptoms and normal X-rays. So MRI has a specificity of the 100% and sensitivity of 90 to 100%. MRI shows the signal change in T1, T2 image in patients presented with the avascular necrosis of the femoral head. So based on the MRI changes, we have how can we diagnose and how can we go for further treatment for avascular necrosis of the femoral head. So we have staging based on the MRI changes for avascular necrosis of femoral head. It is known as modified Piccart-Arlet radiographic staging. So the slide is not clear, but I am reading it. So there are the four stages of avascular necrosis of the femoral head. Stage 0 is preclinical and pre-radiological stage. When changes have started, but patient does not have any clinical symptoms, and if we go for any radiological investigation, even for MRI, it cannot be surely diagnosed the avascular necrosis of femoral head. So interpretation is only suggestive. So we can start diagnose on the stage 1. Stage 1 is pre-radiological. Pre-radiological means in X-ray, we cannot diagnose this avascular necrosis at this stage, in pre-radiological stage. Interpretation in MRI, we can see minimal osteoporosis, blurring of the bony trabeculum. So in stage 2, there are the two different stages, 2A and 2B. The bone try to repair the what are the damaged cells. Damage happens in the femoral head. Stage 2 is we can see diffuse osteoporosis of the femoral head, sclerosis of the femoral head, and cyst, bony cyst. The empty areas of the bone we can see is the cyst in the MRI. In stage 2B, when it progresses in stage 2B, we can see a linear subcortical lucency beneath the articular cartilage of the femoral head. The crescent sign, it is the typical pathognomic in the MRI crescent sign, and it can be we can start seeing these changes. We can see in the X-rays at this stage in stage 2B. We can see subarticular cortex may remain attached to the cartilage, but it is separated from the underlying femoral bone by soft tissue axal side and joint space widening. In stage 3, when more area is involved, like approximately more or less 30% of femoral head got involved, we can see early collapse of the femoral head. When cell death happens, the cancellous bone start collapsing. So we can see the loss of the spherical shape of the femoral head in the X-ray and even in the MRI. So sequential collapse and loss of the sphericity of the head, it is a stage 3. When loss of the spherical femoral head causes the friction forces with articular cartilage of the acetabulum, we can it starts the changes of the femoral hip arthritis. So progressive degenerative disease, it is the stage 4. So degenerative joint disease with joint space narrowing with marginal osteophyte formation and subchondral cyst formation. So it is the stage 4. We can start the changes. We can start see the changes in the X-ray from stage 2B. Up to stage 1, stage 2, it can be only diagnosed on the X-ray. So it is the presentation and graphic presentation of the stages. The stage 1 is the only minor osteopenia. We can see this. We cannot see these changes in the X-ray. So we can just diagnose osteopenia from the MRI in the femoral head. In stage 2, as you can see in the femoral head, there is a cyst we can see and sclerotic lesion. So it increase in the density of the femoral head as a part of repairing mechanism. In stage 3, it starts collapsing when under subchondral bone, the bone below the cartilage layer of the femoral head start collapsing. The femoral head lost its spherical shape. So out of range appearance is stage 3, and stage 4. In stage 4, friction forces between the atypical femoral head and acetabulum can cause the loss of the cartilage on both sides, and secondary osteoarthritis can develop. So in X-rays, first is the X-ray images and second is the MRI images. So stage 0, we cannot see almost any changes in the X-ray and even in the MRI. In stage 1, X-ray looks almost normal, but in MRI, we can see some signal changes, transient osteopenia in the femoral head. Stage 2, there is a crescent sign with the arrow, but it cannot seen clearly in on the screen. So crescent sign can be seen in the MRI, the loss of the cyst formation, the white cyst formation, and multiple islands of the femoral head involvement can see in the MRI. In stage 3, loss of the we can see the loss of the spherical shape even in the X-ray, and MRI is also very diagnostic. And stage 4, it is a gross hip arthritis, so we can diagnose it easily with the X-ray. So treatment depends on the stage of the stages of the AVN of the MRI and X-rays, plus age, physical fitness of the patient, and symptoms of the patient. So treatment depends on these multiple factors, not single factor. So once developed, AVN is almost irreversible. No drugs can restore the blood supply of the femoral head. So it is not like that it is an irreversible process. So first, in initial stages, what we can do is the medical management to delay the progression of the avascular necrosis of the femoral head. So, medical management helpful in early stages of the disease before the collapse of the femoral head in stage 2B. So, when in stage 2B femoral head start collapsing, the pain will increase. So, medical management will have just a supportive role for pain relief. So, what we can do, we can advise the patient when diagnosed with hip pain and stage 1 or stage 2A changes in the MRI. We can start patient. We can tell the patient to have assisted weight bearing to decrease the pain in the hip joint. Physical therapy strengthening the hip musculature will decrease the load on the hip joint and it will decrease the pains. It will give some pain relief and it at least it will continue to have flexibility in the surrounding of the hip joint. Analgesics, we can give NSAIDs. Tramadol can be given for a shorter period of time. Bisphosphonate is helpful in preventing the collapse of the femoral head. So, if patient have a presentation in stage 2A, the bisphosphonates regularly for 3 years can be given as per research and data. So, it can prevent it has a role in preventing the collapse of the femoral head. Blood thinners like ecosprin or statins have a controversial role. So, given with the hope of improving the blood supply of the femoral head, but it has a non-conclusive result at present. So, this is the medical management. In early stages, we can give some pain relief, physical therapy, bisphosphonate, which will prevent. Bisphosphonate is the only drug which actually helps in preventing the collapse of the femoral head if the patient presents in the early stage. And blood thinners we start ecosprin usually that if any thrombotic or thromboembotic phenomena, it can improve the blood supply to the femoral head, but it has a non-conclusive result. Other drugs which can help is calcium plus D3, which helps in the reparative process in the femoral head and help in the preventing the collapse of the femoral head. With all above medical management in early diagnosed hip AVN, disease progresses at different speed. So there is no conclusive data still available of disease progression even with medical management. But research, so this management is surely helpful to the patient. Surgical management, if patient does not have relief with the medical management, then we can think about the surgical management. It also depends on the stages of the AVN. So in the stage when no collapse of the femoral head happened, so up to the stage 2 of early stage 2 means stage 2A of AVN in MRI, surgical management done to improve the blood supply of the femoral head, that is the joint preservation surgery. It is known as core decompression of the femoral head. When collapse of the femoral head happen after stage 2, if and patient does not have relief with medical management, then total hip replacement is the only choice. So joint preservation surgery can be effective only when femoral head collapse does not happen up to stage 2A. When femoral head collapse happen, there is and no patient does not have relief with conservative management and having difficulty in day-to-day activity, total hip replacement is the only choice. So we'll go in a little bit detail of the core decompression and total hip replacement. So in core decompression, what we do, we drill one or several holes in the areas of the dead bone where blood supply is decreased on the based on MRI. So in MRI, we target the areas in different images, sagittal, coronal, and we see the in which areas the femoral head is involved. And under IITB live X-ray machine, we'll target that area and we'll make the several drill holes in that areas. So what is the principle of this surgery? It decreases the compartment pressure in the femoral head. So it decreases the compartment pressure and helps in the regeneration of the blood supply. So it doesn't cure the AVN, but just delays the process of the disease in some of the patient. With even in the ideal stage patient, it has only 40 to 50% success rate in AVN patients. So if patient presented with without femoral head collapse and we do surgery, this surgery has a limited success rate of 40 to 50%. As per recent research, we can combine it with the other multiple therapies like stem cells, bone graft in drill hole. But it is also having the same success rate results. So this is the graphical presentation of surgical planning. So we can see the lesion in the left side first slide. That is, we can target this lesion in the live X-ray machine and based on the MRI and X-ray images. So we'll do the with drill hole. We target the pin drill hole and we make the multiple drill holes in the surrounding area. So it is the AP image. This is the on the righter side. It is the lateral image, and we can see AVN lesions, and we can target and do multiple drill holes and decrease the compartment pressure. So, in surgical management, the other thing we can do is total hip replacement. In total hip replacement in patient with advanced stages with femoral head collapse, it is the ideal treatment. When no, and this patient will always use the in any patient we always use the first trial of the medical management without the frank developed hip arthritis. We always use the medical management as a first choice. When no relief with the medical management happen, then patient can be offered total hip replacement. What we do in this surgery, we remove the femoral head, resurface the acetabulum and femoral canal, and implant the prosthesis in acetabulum and femur. So, this is a graphical presentation of what we do in total hip replacement. We remove the femoral. First, we dislocate the femoral head, then remove the femoral head. Then we remove the acetabulum till the bleeding cancellous bone appears, so that it can integrate with the implant prosthesis metal. So first the acetabulum cell is inserted, then we apply the liner over the acetabular cell. Then we open the femoral canal, remove the femoral canal, and insert the femoral stem in the femoral canal, and we apply the femoral head over the femoral stem and relocate the joint. So total hip replacement has many designs. This is the basic some basic knowledge regarding total hip replacement. So different designs and materials in hip replacement is available. So it is consist basic two components, ball and socket components. So ball components can be highly polished metal, or in recently available is the ceramic design, which has a longevity more than the metal component. Socket component consists of the plastic, that is the high molecular weight polyethylene, or it can be of ceramic or it can be of metal. Choice of the material, as you know, if you know any patients of total hip replacement, that patient can be del metal on poly or ceramic on poly, in which prosthesis type patient has to undergo. So it is there is a typically there is three interface. As in the left hand first side is the metal on polyethylene. This is the most commonly used. It is the longevity of metal on polyethylene is approximately 20 to 25 years. Second is the metal on metal, but due to metal release, it has been withdrawn. And third, most commonly using in young patient is ceramic on metal and ceramic on poly. And fourth thing is ceramic on ceramic. So total hip replacement could be cemented or cementless. Nowadays, we usually use the cementless femoral stem. So decision is based on the number of the factors like age, quality of life, and strength of the bone and cost factor in some instances. Cemented hip replacement is little bit cost effective. Uncemented is a little bit costly as per patient. So surgeon can decide and choose that meet the patient's need. So longevity of the implant is usually metal on poly, which is the most commonly used, is the 20 to 25 years, and ceramic on poly 30 to 35 years. So ceramic on poly is advisable in young age patients. So what is the post-op rehabilitation after total hip replacement? So patient starts partial weight bearing from first post-op day with walker, followed by the gradual full weight bearing within the 3 weeks. So 3 weeks the time that femoral stem and acetabular cell start integrating with the post bone. So we'll start full weight bearing with support within the 3 weeks of the period. So usually we advise to avoid cross-leg sitting and Indian toilet use after THR for at least 6 months due to risk of the dislocation. But recently, dual mobility total hip replacement has also been introduced, where chances of the dislocation is nearly zero. So, in new entity is the post-COVID hip AVN. So it happens in many younger patients. The patients usually presents in the age group of approximately 20 to 35 years. So causes, it is hypothetically causes associated with hypercoagulable state in the COVID-19 disease plus steroid use. But in many patients, when we take the history, patient does not have any severe disease during COVID-19 and does not have any admission, or patient may not have taken any steroid post-COVID in post-COVID hip AVN. The disease is usually aggressive than usual presentation of other patients. So it is the rapidly progressive. Core decompression surgery even before the femoral head collapse has no role. The patient has a rapid progression of the disease, and core decompression is a very high failure rate. So patient requires THR in early stages also due to acute presentation. Even without the femoral head collapse, patient can have very severe pain for which total hip replacement can be offered. So what can be the role of the primary care physician? Identification at early stages to delay the progression. We cannot reverse the process, but at least we can delay the progression in young age patients specifically. So any patients with front side hip pain, pain referred from the hip to knee joint or limping for more than 1 month, always suspect the AVN hip, even in the younger patient. Judicious use of the steroids in routine practice and counseling of the patients to avoid the self-drug abuse by the patient. As still in our practice, most common cause is steroid use AVN. So when we take history, patient has almost patient will have a history of steroid intake. We can give analgesic calcium D3 for symptomatic relief. MRI, if we want to diagnose, then MRI hip is the gold standard to confirm our diagnosis. And whenever you think then it is AVN hip has been developed, you can refer this patient to the joint replacement surgeon. This is the short video of the total hip replacement and exactly how process happens. It is graphical. So this is the femoral head. This is the acetabulum. This is how the osteoarthritis develops, and femoral head got collapsed, and AVN hip changes develop. Subchondral bone collapse happen. This is the acetabular component with acetabular cell and liner, and the second is the femoral component with femoral stem and femoral head. So in surgery, we go through the posterior anterior approach. We usually go through the posterior approach. So we cut the tensor fascial lata and cut the external rotators of the femoral head surrounding the femoral head, and we dislocate the femoral joint of hip joint first. So we cut the femoral head. This is the actual surgical video of myself. So we cut the femoral head. Then we expose the acetabulum. The acetabulum has to rim till the bleeding cancellous bone appears because so it can get integrated with the metal of the acetabular cell. This is how the femoral acetabular cell inserted, femoral liner inserted. We open the femoral canal and insert the femoral stem in the femoral canal. This is how we insert the femoral head. This is how we can see the joint after the total hip replacement. Thank you. So we can have some questions regarding hip AVN or total hip replacement.
You can stop the screen sharing, Dr.
Yes,
Kishore.
sir. Yes, sir. Yes, sir.
Thank you very much for excellent overview of AVN and some management aspects also. It was really very informative.
Yes,
so now it's open for discussion, questions, answers, and comments.
You did not give age breakup of your cases.
What, sir?
Age breakup.
Age breakup, sir. Mostly, frankly speaking, in our practice at present, we usually get the patients between 20 to 40 years, most commonly. So at younger patients in sickle cell, just yesterday I operated patient of 21 years. So in sickle cell, it happens in very early age. So we found the sickle cell AVN patient between the age of 17 to 25 or more, maximum 30 years. So they develop within the age of 18 to 25. So, and in other patient with steroid or alcohol use, we usually find in the middle age. So approximately around 30 to 50 is the middle age in patient with the steroid or alcohol abuse. Because of they'll start in young age, then will start cumulative dose, and they develop the AVN approximately between 30 to 50 years of the age. In old age, AVN is as such, it is very uncommon. It mostly in old age, it is developed secondary to neck femur, traumatic. That's like neck femur fracture, or patient has been operated for IT femur fracture or any other fracture, and then patient can develop the AVN of the hip joint. So more or less it happens in the young age. So we prefer to advise, if in young age patient below the 45 or 50, to use the Ceramicon poly, Ceramicon poly hip replacement to have a longevity, almost one lifetime surgery after that. So it happens in young age, sir, mostly. Young age group is between 20 to 40 years age, surgical operated patient.
In old age, it is more osteoarthritis rather than AVM.
What, sir?
In old age, it is more of osteoarthritis.
Yes, sir. Yes, osteoarthritis. But in hip, it is very, very uncommon, sir. If patient have a history of rheumatoid arthritis or something like that, and develop the knee arthritis, and then sometimes even in rheumatoid arthritis, hip arthritis is very common. Specifically, it presents hip arthritis is more commonly presenting with ankylosing spondylitis patients. So it can happen in ankylosing spondylitis patient in little bit middle age, like 35, 45 surrounding age. So in old age, it is mostly associated with traumatic factors, sir.
Good, thank you.
Any other comments or questions?
How costly are these
implant
prosthetic implants?
Sir, with Ayushman, we use in Ayushman patient Ayushman card. When with introduction of Ayushman card, we use the Indian implants, which is little bit cost effective, but we don't have a data of longevity of the implant. So we always explain to the patient. But in Indian implants are between metal on poly. If we are using, it is between 50 to 60,000. Imported, which is the gold standard, we usually use in any Mediclaim, cash, or any other patient. We usually in young patients even we explain it is surrounding metal on poly is around 85,000, and ceramic on poly prosthesis is around 1,10,000. So other newer trends which has been introduced is dual mobility. So movement happen with the acetabular cell, liner, and femoral head. So movement happen at 3 levels. So chances of dislocation is very less. So that cost around 1,50,000. So it is a little bit costly implants. But Indian implants are a little bit cost effective than imported.
Okay. If there are no more questions, we end the session. Thank you, Dr. Kishan. And for everyone to know, Dr. Kishan had agreed for this talk with a very short notice of less than 36 hours, because we had some problems with the dates of the speakers. So thank you very much, Dr.
Thank you, sir,
for joining us.
Thank you, sir. Thank you for allowing me. Thank you, sir.
Thank you all. We meet next Saturday morning again. Thank you.
Sure, sir. Thank you very much.